Dear colleagues, today in this webinar we will discuss about the healing of post-extraction sockets and the concept for ridge preservation. During the presentation we will try to discuss in details the dynamics of spontaneous healing in post-extraction sites, ridge volume alteration following tooth extraction, the concept for ridge preservation, and at the end also the concept for ridge augmentation. We know that following tooth extraction we have a series of changes regarding the healing of the alveolus, and basically we have an intra-alveolar process of healing and an extra-alveolar process of healing. Regarding the intra-alveolar process of healing, this was discussed in 2003 in this paper published by my brother Giuseppe together with Maurizio Araujo and Jan Linde, and published in 2003 on Journal of Clinical Periodontology. It was a dog model study. They were able to perform a series of extraction of lower premolars, and they were able to perform histological analysis after 1 day, 3 days, 7 days, 2 weeks, 1 month, 2 months, 3 months, 4 and 6 months after root extraction, in order to understand the volume occupied by different tissues like coagulum, granulation tissue, provisional connective tissue matrix, mineralized bone, and bone marrow. And we can see that right after tooth extraction, after 1 day, the socket is filled with a blood clot. After 3 days, we have fibrinolysis. After 7 days, the socket is filled with a provisional connective tissue matrix that after 14 days is replaced by the first stage of mineralized tissue, that is the woven bone. And after 1 month in dogs, we have the peak of mineralization with this image showing the presence of a lamellar bone 1 month after tooth extraction. In 2005, another paper was published by Maurizio Araujo and Jan Linde. Again, it appeared on Journal of Clinical Periodontology. This time, they evaluated the healing of post-extraction sockets 1, 2, 4, and 8 weeks after extraction. And this time, the analysis was performed with cuts, histological cuts that we can see here. On the right, we have the buccal bone plate, and on the left, the lingual bone plate. After 1 week, 2 weeks, 4 weeks, and 8 weeks. The blue dotted line connects the most coronal peak of the buccal bone plate from week 1 to week 8, while the yellow dotted line connects the most coronal peak of the lingual bone plate for week 1 to week 8. And we can see that while the lingual bone peak remains stable, the buccal bone peak has a huge resorption in the vertical dimension that was measured after 8 weeks in a mean 2.3 millimeters of remodeling. And the remodeling is due to the resorption of the bundle bone. The bundle bone is a thin layer of cortical bone that surrounds 360 degrees the inner layer of the fresh alveolus, and it is in direct contact with the periodontal ligament. It receives supply from the periodontal ligament. And once the tooth is extracted, the periodontal ligament will be resorbed, and in a few weeks also the bundle bone will be resorbed. From the radiological point of view, the bundle bone is the same structure that we know as lamina dura dentis. And we can see in this surgical image that after tooth extraction, we have some bone here inside the alveolus, and this is cortical bone. This is what we call the bundle bone. The bundle bone does not belong to the proper alveolar ridge, but it is a bone tissue structure that belongs to the tooth and to the alveolus. In 2003, Lars Schropp published this paper evaluating the bone remodeling in humans following single tooth extraction in the posterior area 1 year after healing. In 46 patients, he was able to evaluate that in average we have a 50% of a reduction of the original volume of the ridge from 12 millimeters to 6.1 millimeters. So this is what we can have in our daily practice following tooth extraction for single tooth if we wait for spontaneous healing of the fresh extraction socket. And we have some drawings here, some images that try to clarify the dynamics of healing in the intraalveolar process of healing together with the extraalveolar process of healing. On the right, we have the buccal side. On the left, we have the lingual side. Right after tooth extraction, we have bleeding inside the alveolus and spontaneous blood clot stabilization. After a few days, the blood clot is resorbed due to fibrinolysis, and we have the formation of a new connective tissue matrix. This provisional tissue matrix will be replaced by new mineralized tissue, and starting from the apex, moving to the coronal portion of the socket, we will have a new bone formation. At the same time, at the entrance of the socket, the soft tissues will heal, and more bone will come from the apical portion. At the end of the healing, the bundle bone will be completely resorbed. The former alveolus will be filled with new bone. So from the qualitative point of view, we could be satisfied. But from the volume point of view, we can see that we have a remodeling of the ridge, both in the horizontal and vertical dimension. In a consensus conference that was published in 2012 by Chris Hammerle, we can see that the alveolar ridge undergoes the following dimensional changes within 6 months after tooth extraction. These data are in humans, not from animal studies. And we can see here that in average, we have an horizontal reduction in the ridge width, the horizontal dimension, of 3.8 millimeters. And in average, we have a vertical reduction, the ridge height, of 1.24 millimeters with spontaneous healing 6 months after tooth extraction in our patient. Here we can see a lower molar with intact soft tissues. The extraction was performed with a minimally invasive procedure, preserving the original anatomy of the soft tissues, separating the roots and preserving the interradicular bone. But despite this minimally invasive procedure, after 4 months, we had a huge remodeling of the ridge in the horizontal dimension. Maybe we lost about 50% of the original dimension of the ridge in the horizontal volume. This is a very interesting and very important question. This is a key question. Can we avoid this bone resorption? Maybe we can graft the socket using a biomaterial and try to avoid this remodeling. Let's have a look to the data that we have today and we can share together. In 2008, Maurizio Araujo published another paper. It was a control study in dogs. The distal root of the 4th lower premolars was removed, and in the test group, the alveolus was grafted with demineralized bovine bone mineral. In the control group, the alveolus was left for spontaneous healing, so just blood clot stabilization. Araujo wanted to measure the alteration in percentage of the ridge volume in different zones of the extraction socket. Here, on the left, the control group, blood clot. On the right, test group, the socket grafted with demineralized bovine bone mineral. In the most coronal portion of the ridge, that is the one that we know is the most important from the functional and aesthetic point of view. In the control group with spontaneous healing, we had about 30% of volume loss, remodeling with a loss of 30% of the original volume of the ridge. In the test group, grafting the socket with the demineralized bovine bone mineral, the ridge volume remained stable, plus 1.7%. In conclusion, we can affirm that the dimension of the hard tissue was maintained and the profile of the ridge was better preserved in the test group. The placement of a biomaterial in an extraction socket may promote bone modeling and compensate for marginal ridge contraction. This terminology is really important, to compensate for marginal ridge contraction. With a ridge preservation procedure, we cannot avoid the resorption of the bundle bone, because once the tooth is extracted, the bundle bone will suffer from a lack of supply. And so the bundle bone will be resorbed anyway. There is no possibility to avoid the resorption of the bundle bone. But grafting the socket with biomaterial, we can compensate for this marginal bone remodeling. And so for the treatment of extraction, we can introduce the concept of ridge preservation. That means preserving the ridge volume within the envelope existing at the time of extraction. The concept of ridge preservation is a little bit different from the concept of ridge augmentation. Because ridge augmentation, it means increasing the ridge volume, not preserving, but increasing the ridge volume beyond the skeletal envelope existing at the time of extraction. Basically, the main difference between ridge preservation and ridge augmentation is the clinical indication to these two different procedures. We can use the ridge preservation approach when the volume of the ridge is intact, or we have just a small resorption that is no more or 20%, or maybe just something around 1 millimeter of bone resorption. But, for example, if the buccal bone is missing, well, in this situation, we cannot use the ridge preservation technique, but we have to move to the ridge augmentation technique. So ridge preservation, in the left we can see if the buccal bone wall is intact, but if the buccal bone wall is lost, like in the image on the right, we have to work with the ridge augmentation concept. Now let's speak about the. We can see that basically it means to extract the tooth, to check for the integrity of the bone walls, and then to graft the fresh extraction socket with a biomaterial. In this way, we can avoid the remodeling of the post-extraction socket. One key question is, from the surgical point of view, in which way we can protect the graft. What kind of possibility we have? Giving a look to the literature, we know that the socket seal was introduced by Landsberg in 1997. With the socket seal, we harvest an epithelial connective tissue graft from the palate. And with this graft, we protect the socket. We seal the socket. So we can have at the same time the biomaterial inside the socket and the autogenous soft tissue graft sealing the coronal portion of the socket. We have also another possibility, flap advancement. So we can raise a flap, advance the flap in order to obtain first attention closure. But from a periodontal point of view, we know that with this approach, we will lose the original level of the mucogingival junction, because we will move the mucogingival junction maybe 10-12 millimeters in the coronal portion, losing a lot of keratinized tissue. And with the socket seal on the other hand, we know that we increase the morbidity of the procedure, because we know we have the need to go to the palate, harvest some tissue, and we increase the risk for bleeding and pain in the post-op. For this reason, few years ago we introduced the concept of open healing. Open healing, it means to use a collagen resorbable membrane to cover the biomaterial and to leave this collagen membrane open in the mouth of the patient without the need to reach a first attention closure by the soft tissues. So the soft tissues we will heal by second attention. In about 3 to 4 weeks, we have a complete closure of the soft tissues. We can see in this clinical case, on the first image on the left, we have that is left exposed after tooth extraction and grafting of the socket. After 2 weeks, the sutures are removed, and this yellow tissue that we can see is not infection. It is a layer of fibrin that is covering the membrane. So under the fibrin, we have the membrane still in place, protecting the biomaterial. So we just have to wait, in average, 2 more weeks. And in about 3-4 weeks after extraction, we have a complete closure of the soft tissue. And after 4 weeks, we have the ridge healing process that is completed. And after 4 months, we have also a satisfactory bone healing. And the bone tissue is able to receive our implant. We can see this clinical case. It is an upper premolar. This tooth is opless. We performed a flapless extraction, preserving the original anatomy of the soft tissues. After root extraction, the socket is debrided and rinsed with saline solution. And then we graft this biomaterial. This is a bovine bone mineral that is blended with a 10% of collagen of porcine origin. So it is like a mix between bovine bone granules and collagen blended together in order to improve the handling of this biomaterial. And then the biomaterial is protected with a resorbable native collagen membrane that is trimmed to the original size of the socket. And then the membrane is not sutured, but we use usually a horizontal cross-mattress suture to keep in place the membrane. And if we need, we can use some additional single sutures. After the procedure, patients will take antibiotics, generally amoxicillin plus clavulanic acid, 1 gram every 12 hours per 6 days. They will rinse with chlorhexidine, 0.2% 3 times a day for 2 weeks until suture removal. And they will apply a gel rich in hyaluronic acid and 4 different amino acids to be used on the top of the membrane, where we have second attention healing in order to improve the healing of the soft tissues. On the left, we have the image after 2 weeks, and on the right, we have the image after 4 weeks. We can see complete closure of the soft tissues. And now we are 4 months after tooth extraction. We can see the lateral image and the occlusal image. The original volume of the ridge was preserved. We performed a randomized controlled clinical study that was published in 2012 in the International Journal of Periodontics and Restorative Dentistry. We evaluate 41 patients for a total of 48 teeth that were hopeless. They were extracted and divided into 2 groups of treatment, test group and control group. In the test group, the sockets were grafted with demineralized bovine bone mineral blended with a 10% of collagen and then protected with a native collagen membrane. In the control group, the sockets were left for spontaneous healing. After 4 months, on cast models, we evaluate the volume of the ridge, and also we performed histological analysis in order to understand the histology of the new tissues where we will place the implants, because after 4 months, 48 implants were inserted. This is a clinical case from the test group. Tooth extraction, always performed with a flapless approach. The socket grafted with the biomaterial and protected with the resorbable collagen membrane. Some horizontal mattress sutures in order to keep in place the membrane. This is the image after 2 weeks, the day of suture removal, and after 4 months, when the healing is completed. This is another premolar. This is the same case, and we can see on the left the image at baseline, and on the right the same image after 4 months. So the profile and the soft tissue contour of the ridge remain pretty stable. This is another case. This is a case from the control group, tooth extraction and spontaneous healing. Also in this case, tooth extraction was performed flapless with a minimally invasive approach. And just with the spontaneous stabilization of the block cut, we can see here that after 4 months, we have a huge remodeling of the ridge, specifically more on the buccal side. These are the outcomes. In the socket preservation group, the test group, the difference in the width of the ridge, the horizontal dimension, was 1 millimeter, 1.04 millimeter, corresponding to 7.7%. In the control group, with spontaneous healing, the remodeling was 4.5 millimeters. That was the 33.48% of remodeling in the horizontal dimension. The difference was statistically significant. Regarding the vertical dimension of the ridge, the height, in the test group with ridge preservation, we had just a 0.46 millimeter of remodeling, while in the control group with spontaneous healing, the vertical dimension had a remodeling of 1.54 millimeters. So with spontaneous healing, we have 3 times more volume loss in the vertical dimension than what we had with ridge preservation. And these are the data from the histological analysis. In the test group, after 4 months, we had 26% of new bone, 18% of residual graft, and the mineralized fraction was 44%. In the control group, of course, we had no residual graft, and so the mineralized fraction was 43%. So we can see that the difference in mineralized tissue between test and control group was not of statistical significance. And I want to share with you the beautiful images that we had from the histological analysis. These are the soft tissues following open healing with secondary attention closure. We have no inflammation. This is the epithelium. We have the lamina propria between the epithelium and the connective tissue, and here we have the connective tissue at 50 magnification. And then we can go deep in the bone, and after 4 months we have new bone. This is woven bone surrounded by osteoid with a lot of osteoblasts here waiting for delivery new mineralized tissue. We still have some granules of the biomaterial. This is a granule of bovine bone mineral with some osteoclast here that will resorb this granule. At 200 magnifications, we can see here a big piece of new bone, woven bone, in direct contact with some biomaterial, some granule of demineralized bovine bone mineral. And at 400 magnification, we can see again woven bone, osteoid, osteoblast inside the osteoid. So all this tissue will be mineralized in few days. The conclusion of the randomized control clinical trial were that with ridge preservation, we had just a small remodeling of the ridge that was 1.04 millimeters in the horizontal dimension, corresponding to 7.7%. While with spontaneous healing, we had 4.48 millimeter of remodeling, with in percentage at 33.48% of remodeling. The difference was of statistical significance. And we can see here in this drawing that maybe it is easier to understand that with ridge preservation we maintain a 26% of more bond in the horizontal dimension and a 70% of more bond in the vertical dimension. Socket preservation using bovine bone mineral and porcine collagen membrane is able to limit the amount of horizontal and vertical bone resorption when compared with tooth extraction alone. From the histological point of view, the xenograft material ensures a large mineralized fraction with formation of new bone. In 2014, we published another randomized controlled clinical trial. Again, to compare the dimensional ridge alteration before and after tooth extraction. But in this study, we didn't perform measurements on cast models, but all the measurements were performed intrasurgically, so directly on the bone using a bone caliper. And then we wanted also to analyze the influence of buccal bone thickness at the baseline upon ridge remodeling. This is the test that we performed. It is a linear regression analysis in order to understand if there was a statistically significant correlation between the alveolar bone loss after 4 months and the initial cortical bone thickness. In the test group, the answer was no. There is no correlation between the thickness of the buccal bone plate at baseline and the remodeling of the post-extraction socket. While in the control group with spontaneous healing, yes, we have a correlation, and this correlation is negative. So we can conclude that the ridge preservation limits the amount of bone resorption when compared with tooth extraction alone. No correlation is found between the buccal bone plate dimension at the baseline and the alveolar bone loss, so that we can say that socket grafting seems to be able to compensate alveolar contraction independently from the buccal bone thickness, while in the control group with spontaneous healing, thinner the buccal bone plate, greater the alveolar bone loss. So this is what we do to compensate. With ridge preservation, we cannot avoid the resorption of this thin buccal bone plate, but after 4 months, since we have grafted the socket with the biomaterial, we were able to compensate and we have the volume suitable for implant placement. This is a systematic review published by Gustavo Villa-Ortiz on the Journal of Dental Research in 2014, comparing several different procedures for ridge preservation, comparing the use or not the use of a membrane to protect the graft, and the difference between several biomaterial, xenograft, allograft, autogenous bone, and alloplast. And we can see here that the study that we have published in 2012 really gave good outcomes, more than what we can have in average with ridge preservation, using the membrane. And the subgroup by type of bone graft, we can see that the xenograft perform very well, because usually the xenograft are biomaterial with a slow resorption rate, so that they are able to maintain the volume. And what about the implant placement? After 4 months, we know that we need bone in order to place an implant. We can see this case, an upper premolar with ridge preservation, and after the healing of the soft tissues first and of the bone after 4 months, we are able to place an implant because we have a lot of bone in the horizontal dimension and also in the vertical, in the posterior area of the maxilla. With the ridge preservation, we can avoid also the pneumatization of the sinus. And so we maintain the original dimension of the ridge also in the vertical height. And so we can open the placement. This is a conical tapered implant, and we can also understand here that we were able to reach primary stability, very positive, very good primary stability, 35 Newton per centimeter. And with this kind of primary stability, if we want, we can load the implant in 6 weeks. That was published in 2015. In order to evaluate the insertion of osseointegrated implants in alveolar ridge previously preserved with a bovine bone mineral and collagen membrane, and to compare with osseointegrated implants inserted in spontaneous healed ridge. So we wanted to understand if after 4 months from ridge preservation there is a real benefit from the ridge preservation or not, or it is the same to place an implant in a previously preserved ridge or in a spontaneously healed ridge. And so we evaluate implant stability quotient, marginal bone level, survival rates, success rates, and the need for additional guided bone regeneration procedure the day of implant placement. We can see here it is an upper premolar test group, and after 4 months with ridge preservation we have a lot of bone where to insert the implant. And this is a control group, spontaneous healing, and 4 months after spontaneous healing, we can see here the buccal bone plate is very thin, and so the implant was inserted, but we needed to perform an additional guided bone regeneration procedure, in this case an horizontal augmentation, in order to compensate for the remodeling of the socket. And so the outcomes that we found in our study are here. In the test group with ridge preservation, the implant stability quotient was 69, in the control group 70, so no differences between the two groups from the statistical point of view. And also the marginal bone level was at 0.31, 0.35, 0.38 at 1 year, both on the mesial and distal side of the two groups. No statistical difference. The survival rate was 100% in both groups, no statistical difference, and the success rate was 95 in the test group and 91 in the control group, no statistical difference between the two groups. And what about the need for additional guided bone regeneration procedure the day of implant placement? In the test group with ridge preservation, only 1 implant out of 24 needed an additional guided bone regeneration procedure the day of implant placement. It is only 4%, while in the control group with spontaneous healing, 14 out of 24 implants needed an additional bone regeneration procedure the day of implant placement, almost 60%. It means that the 6 implants out of 10, when we have spontaneous implant or spontaneous healing, the day of implant placement, they will need an additional guided bone regeneration procedure, and this will increase the morbidity and also the economical cost of the procedure. The 1-year results confirm that implants inserted in augmented sites present comparable success rates and marginal bone level to that of implants inserted in non-augmented sites. So the bone that we have following ridge preservation, it is a woven bone, but it is able to positively receive implants, and after 6 weeks we can load the implants and have the same outcomes regarding survival rates, success rates, and marginal bone level if compared to implants inserted in native bone. Now we can introduce the concept of ridge augmentation. We use ridge augmentation when we have lost the buccal bone. So cases like this, we can see here. We needed to extract an upper lateral incisor, cuspid, and first premolar, and we can see from the surgical point of view that we have a lot of bone loss due to the periodontal infection. In this case, the procedure we can see is different. We have to open the flap, to graft the sockets, and to protect with a membrane. And then again, also with the ridge augmentation, we close the flap, of course, but we don't need to achieve primary attention closure. So we can see here that we have small amounts of the membrane that is exposed. So this is a typical approach for ridge augmentation. It is like a guided bone regeneration procedure the day of tooth extraction without implant placement. Basically, we can have two approaches. One, it is a flapped approach, and another one, it is a flapless. We will see two clinical cases with these two different surgical procedures. This is an upper cuspid. We can see that we have a fracture of the root, and the fracture of the root led to a huge resorption of the bone on the buccal side. So the buccal bone is completely missing. We can see here after tooth extraction. This is the palatal level and this is the buccal level. What we can do at this time? We cannot use a ridge preservation procedure because the buccal bone is missing, and I think it's not a good idea to place an implant at this moment. So we want to augment the volume of the bone. And so we graft the socket, but we place some granules of the same biomaterial also on the buccal side to create like an over-contouring of the ridge. And the graft is again protected with collagen membrane. This is the sutures, and we can see here the amount of the membrane that is left exposed for open healing. Also with ridge augmentation, we use the approach with open healing. If after 4 weeks, we can see here the beautiful healing of the soft tissues. Almost everything is closed. We just need to wait 1 or 2 more weeks. And after 6 months, we have a complete healing of the ridge from both the point of view of the soft tissues and the hard tissue, and we can open the flap, and we have all the bone that we want and that we need to place an implant. And this is a lateral incisor, an upper lateral incisor with a prosthetic failure. In this situation, we have a deficiency of the soft tissues because the soft tissue margin is with a recession. It's not stable. We have a recession. It is apical to the margin of the central incisor. And if we give a look to the cone beam evaluation, we can see also that we have lost the buccal bone plate. So it's not a situation where we can perform the usual ridge preservation, but also I know they are not to open the flap to be minimally invasive. And in this situation, we can use a membrane that is trimmed like the ice cream cone technique. So we have 4 wings of the membrane. The long wing is inserted inside the socket in direct contact with the buccal side. Where the buccal bone plate is missing, we place the membrane. With a specific instrument, we can push the membrane inside the socket and create a perfect adaptation of the membrane on the buccal side. Then we have 3 more wings of the membrane itself. 1 on the mesial, 1 on the coronal, and 1 on the distal side. The socket is grafted with the slow resorption biomaterial, we can see here, completely filled with the biomaterial. And then we can fold the 3 remaining wings of the membrane on the top of the biomaterial and with the 6 single interrupted sutures. In this case, I used a PTFE suture. We are able to suture the membrane, to fix the membrane, and everything will close. Look where is the soft tissue margin right after tooth extraction. We will increase in this area the amount of keratinized tissue. This is after 1 week. This is not infection. This is not pus. It's just a layer of fibrin on top of the membrane. But the soft tissue margin already migrated in the coronal direction. And we can see the amount of keratinized tissue that we gain with this open healing approach. After 2 weeks and after 4 weeks, almost completed is the healing of the soft tissues. A lot of keratinized tissue. 3 months, everything is healing perfectly. 4 months, fine. And after 4 months, we are ready. We can open the flap. We have a lot of bone. This is the new buccal bone plate, the new cortical bone on the buccal side. We can place the implant. The implant is prosthetically guided. We have all the volume that we want from the point of view of the new bone formation. And then after 6 weeks, we can prosthetically load the implant. Look, the amount of keratinized tissue that we have. And this is the definitive ceramic crown, the definitive restoration, and we are really satisfied about these outcomes. On the left, the image at baseline. On the right, 1 year after implant loading. We can see the difference in the levels of the marginal tissues. So in conclusion, we can say that the dynamics of spontaneous healing in extraction sites is something that we cannot change. Every time we extract a tooth, we have a flat to mineral. Understood that the ridge volume alteration following tooth extraction can be compensated with the use of a ridge preservation procedure. After 4 to 6 months, we have a complete healing of the bone tissue, and we have this tissue where we can place implants and achieve very positive outcomes in terms of the stability of the marginal bone levels. We have seen a lot of histological evidence about the quality of this new tissue. And we have seen also the concept for ridge preservation. When we have lost the buccal bone plate, we can use a ridge augmentation procedure in order to create a new bone plate also on the buccal side, and usually with an open healing, this will also lead to the gain of keratinized tissue. Dear colleagues, remember that we are what we repeatedly do. Therefore, excellence is not an action, but it is a habit. This is what Aristotle in the ancient Greece used to say more than 2,300 years ago. This is the concept of predictability. Thank you.